Well, the costs, unfortunately, are really tremendously high. I think one of the ways for me to kind of conceptualize thinking about it is that if we're actually able to implement this kind of a testing strategy around the birth cohort and reduce morbidity and mortality, we know that we'll be able to reduce cost to the healthcare system by well over at least $1.2 billion. We know that that's a considerable underestimate as well, because when we originally did those models, cure rates were much lower than they are now. And as those continue to increase, we know that these costs will continue to drop more. I don't have an estimate of exactly what these costs will look like, because these things are really changing dramatically right now. A number of these medications coming out, it's quite a variable and fluid situation. But in the absence of having any of these, of actually putting these recommendations into place, I think we would continue to see increased burden, especially in the context of things like liver cancer, as well as more and more liver transplants that would be required.
Outside the liver cancer, just the end-stage liver disease itself. You know, patients develop end-stage liver disease, the medical costs related to readmission into hospitals, they will develop upper GI bleeds. Those, I think an upper GI bleed admission could cost up to $200,000 just for one patient. The progression to liver cancer, liver transplants, screening, linkage to care, and treatments for a large proportion of patients would reduce the costs significantly.
Testing and treatment is very much a cost-effective intervention here in the U.S. There have been a number of studies, I think 6 or 7 at this point, that have shown that the cost-effectiveness of actually testing this population and subsequently treating them is quite dramatically cost-effective in terms of just the number of quality assisted life years that are gained and the relatively low cost of what those are. So it's a very cost-effective intervention.
Plans that are available in the Maryland Exchange exacerbating or helping your patients?
So I am very hopeful they will help. So like the graph showed, majority of our patients, because they qualify for PAC in Maryland, they will get Medicaid, so full Medicaid through our Medicaid expansion program, which is very exciting, because then that makes available to these patients a broader range of services for healthcare. The one question that is still unanswered is what exactly the programs will cover. So they will cover some form of treatment, but the question is which treatments specifically, and we're all waiting to see and find out the answer to that question. So the good news is that I feel confident that majority of our patients will have the insurance coverage to get treated, without a doubt. And that definitely, I think, is a help for our patients.
It's a really good question, and you're right. It very much does depend where you are. Testing rates are quite variable across regions, across cities, just across healthcare systems. Different insurance companies cover different things, and so what you find is we have found that sometimes the range actually even falls outside of that 50 to 75%. It can be tremendously variable. If there's a champion within a local healthcare setting, we find that testing increases, is higher than we would see it in other places. In the absence of that, we find that it really can be tremendously, it could be much lower. Many populations, as few as maybe even 4 to 5% of an entire patient population might be tested. And again, in those settings, you're frequently going to find that about 75% of infected persons there aren't going to be found. We've also found some settings where as high as 40% of patients were tested. And there they found probably at least 60% of all infected patients. But that really is very unusual. That was in the Bronx. They have a very much more high-risk population, much higher levels of HCV. So it's tremendously variable. Depends a lot on your patient population and, of course, the healthcare system that's providing care.
A question for Dr. Smith about primarily looking at strategies to linkage to care. Can you comment on different strategies and knowledge level of different providers in different settings, and how can we transmit, once we screen positive, how can we facilitate and make sure people get the right care?
Right. And that's an excellent point. And interesting, Dr. Falade's group has actually had an awful lot of success in that regard in being able to get persons linked to care. But more often, I think that's actually much more of a challenge. It's once someone is diagnosed, how are you able to link them to something as simple as care? Being able to provide them with counseling, better understanding about what it means to have that infection, being able to provide alcohol counseling. We found that being able to use additional providers, sometimes case management, patient navigators, persons who are able to make sure that a person who's been diagnosed as being infected is actually able to make that first appointment. If they can make that first appointment with the clinician and then start to better understand the disease and their infection and what it is that they can do, they're much more likely to be able to stay on with treatment if that's something that is beneficial for them, something that's appropriate, which should come out in a conversation between them and their physician. But I think really being able to have someone to help patients navigate, which sometimes can be a rather challenging healthcare setting. Sometimes they're not really kind of knowing who it is you need to see, where it is that they may be. Having case managers, patient navigators really helps that a great deal and can increase the number of persons who then access linkage to care.